with problem-based learning, or PBL. This teaching learning method has widely used as part of the integrated system-based curriculum in Faculty of Medicine UKM since 2005. So, without any delay, I would like to invite the first presenter, Mr. Tam Yu Chuan from the Department of Physiology, to present his group study titled Problem-Based Learning with and Without Facilitator.
Thank you. I'm Tom, and I'm representing my group 26. The topic today that I'll be talking about is problem-based learning with and without facilitator. A little bit about background of a study. Problem-based learning was first introduced in Faculty of Medicine in the early 1980s. But in year 2005, UKM adopted the new integrated system-based curriculum. It became one of the main teaching methodology. It was said to promote stronger thinking and problem-solving skills, effective communication skills, and sense of personal responsibility, which we will fairly commonly call it as an independent learner. Previous study has showed that there was no significant difference in students' performance. Problem-based learning is actually a skill, a process from problem encountering to self-directed learning and the end problem solving. So we believe after being exposed to PBL teaching method for quite some time, we believe the students should be able to carry out PBL process by their own. So this leads to our problem statement, which is we want to see how effective is PBL in preparing medical students as an independent learner, and how after 1 year, students will be able to carry out their own PBL discussion. Our general objective is to compare the outcome of PBL class among second-year medical students between PBL group with facilitator and those without facilitator. Specific objectives will be to compare the basic science knowledge, critical thinking skills, motivations, group dynamics of students. We hypothesize that there will be no difference in the students' basic science knowledge, critical thinking skills, motivations, and group dynamic of the students. We sampled the second-year medical students, 191 responded under the neuroscience module, which is the second to last module of their second semester. The reason is that we want the students to be truly exposed to a longer time of PBL process, and by not using the last module, we'll allow them time to prepare for the coming exam. So we used 191 students were divided into 20 PBL groups, each consisting of 10 to 11 students randomly, and 10 of them will be the observed group, while 10 of them will be the control group. The observed group will have the first PBL with facilitator, and the second PBL without the facilitator, while the CAN control group will have both PBLs with facilitator. In the control group, the facilitator will facilitate the PBL process as usual, holding the trigger, dividing it to the students accordingly, and guiding them appropriately to the correct learning issues. While in the observed group, we'll have facilitator there to observe the students in the PBL process. It is required to be there because of the faculty's requirement for the facilitator to assess the students' continuous assessment. However, they will elect a student leader to hold the triggers, and students as a whole, will facilitate the PBL process as usual. Ideally, it will be best done with a one-way mirror, but however, this is our limitations. We assess the basic science knowledge using mini-tests and critical thinking skills, motivations, and group dynamics by using questionnaire. So there were a total of 100 in the observed group and 91 in the control group. So looking across the data from PBL test 1, comparing between the control and observed group, we can see that the observed group scored significantly higher than control group. But in PBL test 2, the control group scored higher than the observed group, but the result is not significant. Comparing within the control group itself of the test score of PBL test 1 and test 2, control group scored significantly higher in PBL test 2. But within the observed group itself, we can see that the observed group scored lower in PBL test 2, but the result is not significant. As an independent learner, as promoted by the PBL teaching methodology, we believe that any of the three components here will empower the students to achieve a greater performance. So we compare the students' critical thinking skill, motivations, and group dynamics. All of them, we found out that there were no significant difference of the students between in the control group and the observed group, except for one component under group dynamics, which is encouraging the peers to communicate. It is significantly higher in the control group. So we believe that it is because of the facilitator's direct presence in the PBL process, and the students were more motivated to prompt other students to encourage their peers to communicate in the PBL process as part of evaluations of a continuous assessment. We collected a fairly number of students' comments. Some feel that the facilitator should be there to guide them to achieve the correct learning objectives and to confirm their discussions. However, some felt that PBL without facilitator will give them an early exposure to learning ways in clinical year. And some felt that PBL with facilitator should be in the first sessions, and the second sessions, they will have PBL without facilitator. Our conclusions is that our study showed that there was no significant difference of students' performance, which is the basic science knowledge, critical thinking skills, motivations, and group dynamic between PBL with and without facilitator. Our recommendation is the faculty could implement PBL without facilitator. However, they will need to monitor the students' progress closely. And the students will need more training to understand their role in the PBL process. We also strongly recommend that a more comprehensive study should be carried out to further determine the prospect of implementing PBL without facilitator. We would like to extend our gratitude to this party involved, and with that, I thank you. Any questions from the floor?
Can I ask you, what is your questionnaire about? And the means SD, the mean and the SD, what are those scores? What are those outcome value?
Okay, the slide, please. In the motivations or the basic science knowledge? Okay, everything. From the PBL test score 1 and 2, we devised 5 questions from PBL test 1 and PBL test 2. The topic they have discussed, and then we assess it. We ask the students to come, and then we assess their test score according. It is OBA questions of 10.
So it's a self-administered question after the PBL session.
Yes, after the second PBL sessions, we administer. Yes.
And then you split it into different domains.
Yes, with 5 questions from the PBL topic 1 and 2 each. And okay.
And the students are aware that they are under study condition.
Yes.
Yes. In observed group, what is the role of students leader? Student leader.
Okay. In the observed group, the students leader role is to hold the trigger. He will not function as a student facilitator because they have not been trained. So the group as a whole, they will determine the flow of the PBL and which trigger should come next. And they determine the flow in another way. Yes?
Okay, for the group without the facilitator, I think the objective of the PBL is to make sure that you achieve the objective of the learning strategy, whatever. Were you given, for those without facilitator, were you given the learning objective for that package?
Okay.
So that it will guide, I don't know, maybe the chairperson, sure the discussion will not go beyond the objective or how? Thank you.
Okay. We use the existence PBL framework in which the objectives of each PBL topic is not given to the students. However, to make sure that the students' result were not affected in the final examinations, after we collected the data, the objectives of the 2 PBL discussed were given, the learning issues were given to the students. At the end of the both PBL sessions, after we collected the data through the mini test and the questionnaires.
How you conduct the PBL if you do not know the objective of that package, you know? How far to go, you know, how the student knows. Okay. Before this, the facilitator will say, you know, what else you will discuss or whatever. But now, how you conduct the PBL? Okay.
As I've mentioned earlier, we took the second year medical students in the second semester, which is toward the end of their second year semester. So throughout this first year and the second year,
sorry.
Let me finish my sentence. Throughout the first year and second year, the students will be thoroughly conversant of the PBL process. So they'll understand when to stop and when the depth and the breadth of the discussions. Thank you.
Thank you, Mr. Tam. Our next presentation will be from the Department of Obstetrics and Gynecology. Their study was to evaluate possible predictors of suboptimal surgical cytoreduction in women with ovarian cancer. Now, I would like to invite Mr. Setujanathan Kupan, Group 23, to present their findings.
Good afternoon to honorable judges, professors, doctors and my fellow colleagues. Today I would like to represent my group presenting my research entitled Predictors of Suboptimal Surgical Cytoreduction of Ovarian Cancer in UKMMC. As we all know, ovarian cancer is the fourth most common cancer in Malaysia, and unfortunately 80% of them present to us when they are already in stage 3 and stage 4. Therefore, the likelihood for the patient to undergo a suboptimal surgical cytoreduction is higher, leaving the morbidity and the mortality also high in this kind of group. What really happens when we receive a patient with ovarian cancer? The current practice says that the clinician will decide to bring the patient for primary surgical cytoreduction, and the surgeon will resect the tumor as much as possible, leaving the residual tumor as minimal as possible. If the residual tumor is more than 1 centimeter, it is classified as suboptimal surgical cytoreduction, which is a poor surgical outcome. If it is less than 1 centimeter, it is classified as optimal surgical cytoreduction, which is actually a good surgical outcome. If we already know it earlier, we may offer them with the alternative therapy, which is a neoadjuvant chemotherapy. How are we going to detect them earlier? There goes the role of predictors. So our objective is to determine whether suboptimal surgical cytoreduction can be predicted preoperatively, and also to determine the rate of suboptimal surgical cytoreduction for ovarian cancer in UKMMC. The predictors that we have looked into in our study are patient's age, CA125 level, albumins level, CT scan parameters like ascites or mental metastasis, lymph nodes involvements, which are divided into pelvic and para-aortic, liver metastasis, pleural effusion, and also tumor bulk. So we collected all the patients who were diagnosed with ovarian cancer in UKMMC since 2002 until 1st April 2010, and based on our inclusion and exclusion criteria, we managed to gather 32 patients, even though our calculated sample size was 27. Our main inclusion criteria is the patient must be C and above, according to the FIGO staging, and the CT scan must be reviewed by a board-certified radiologist of UKMMC. And also the patient must undergo a primary surgery. If the patient has operative CA125 albumin, we need to exclude the patient, and we analyze these patients according to SPSS version 13. Out of these 32 patients, 69% of them had a surgical cytoreduction, leaving only 31% of them had a suboptimal surgical cytoreduction in UKMMC. So when you can see this histogram, in stage 1 patient, 100% of them had a optimal debulking. In 7% of them had a suboptimal surgical cytoreduction. When we analyzed the data, we found that CA125 and ascites is a significant predictor, leaving the rest of the predictors are insignificant. So what does that mean? We decided to use the receiver operative characteristic curve, also known as ROC curve, to find the cutoff value of CA125. at the specificity of 81.8% and sensitivity of 80%, we found that the cutoff value of CA125 value is 270, meaning that those patients who had CA125 more than 270 and above, 67% had a suboptimal surgery. Only 33% had an optimal surgery. For the next, we found that there is association between ascites and also the outcome of the surgery. And in moderate to severe group, we found that majority of the patient had a suboptimal surgical cytoreduction. Absent to minimal, majority of them had an optimal surgical cytoreduction. This is a CT scan image of our patient. So this patient is actually had a tumor, a large tumor over here and also here, and the patient also had a ascites, which is actually a gross ascites, and the patient actually underwent a suboptimal surgical cytoreduction. And the other parameters or other predictors in our study, such as age, omental involvement, liver involvement, pleural effusion, para-aortic lymph node involvement, pelvic lymph node involvement, and also the continuous data, which are albumin and also tumor bulk, become insignificant in our study. So we decided to use a logistic regression to find the significance of CA125 and ascites. Based on odds ratio of CA125, CA125 is a weak predictor compared to the ascites, which are with the odds ratio of 41.929, meaning that if the patient had ascites, the chance to undergo suboptimal surgical cytoreduction increases 41 times. And these two predictors has influence of 60.8% on overall influence of the suboptimal surgical cytoreduction. Next slide, please. So, as a discussion, we found that our cutoff value for CA125 is actually 270. Okay. 270. And Brockbands et al. In 2004 showed that their CT scan, their CA125 level is actually 586. Different between our study and also their study. This is basically because our inclusion criteria. We included all the patients from stage 1C and above. And Brockbands et al. Included patients from stage 3 and 4. Of course, the titer of CA125 among early stage disease patient and later stage disease patient will be different. And this will actually give an opportunity to the surgeon to select the patient even in early stage disease and give a proper management. Okay? Because they might be misstaged or wrongly staged the patient preoperatively. So in ascites, we found that moderate to severe ascites has a poorer surgical outcome. This is consistent with D. Jong et al. In 2007. They also said that a large volume of ascites will yield a poorer surgical outcome, which is actually a suboptimal surgical cytoreduction. This is postulated by Dae Jul Chong et al. In 2009 that ascites will cause a tumor seeding in the peritoneum, which may complicate the surgery intraoperatively, leaving more residual tumor during the surgery. However, the rest of the predictors in our study become insignificant. So why this actually happened to our study? Because a small sample size compared to previous studies. Their sample size were more than 100 and 200. So a small sample size doesn't, it is not that there is no association, but then in our study we failed or we couldn't yield statistically. And this early stage disease patient might not have any complication. Like for example, hypoalbuminemia that is very prominent in later stage patient. In conclusion, ascites of moderate to severe and also CA125, which are more than 270 international unit, may be used as a predictor to select the patient for upfront primary surgical cytoreduction. And leaving the rest of the patient, we may offer them with a neoadjuvant chemotherapy, which is actually supported by Stewart's PE et al. In 2002, saying that neoadjuvant chemotherapy provides a better survival rate. So, in recommendation, clinician may consider to select the patient, and a further study must be done to find the prognosis comparing patient undergoing primary surgical cytoreduction and neoadjuvant chemotherapy, and also to find the side effect of the surgery. I would like to acknowledge all my supervisors and co-supervisors and affiliated departments With that, I thank you. Any questions from the floor?
What was your method of determining the completeness of the surgery?
We go through all the files, the surgical notes of the patients, and we brought in the surgical notes to our surgeon, and we certify them whether the patient had a optimal or suboptimal based on their residual tumor, which they have already noted in the surgical notes.
So it was based on the surgeon's perception of whether the surgery was complete or not.
Most of the surgical notes already stated that this patient had a sub-centimeter or more than 1 centimeter, so we take the data from there.
Were the ascites all cytologically positive?
We didn't really go through for the ascites, but then we went through the histology of the tumor itself. But we didn't go through about the cytology in the ascites.
Prof, excuse me. May I answer that question? I'm his group member. We did not collect any data of ascites cytology because we only collected data based pre-operatively.
Thank you, Mr. Setu. Now, we will have another interesting study, which is on the effect of galam honey supplementation on oxidative status in young and middle-aged rats in comparison to manuka honey. Without further ado, I would like to call upon Ms. Lee Ke Yao, Group 9 from Department of Biochemistry.
A very good afternoon to all the judges, professors, doctors, and my fellow friends. Today, I'm going to present on my group study with the title of Effect of Galam Honey Supplementation on Oxidative Status in Young and Middle-Aged Rats in Comparison to Manuka Honey. In our study, we used Apis mellifera honeys, and they are named Galam honey or Melaleuca species. There's been a previous study done on this Galam honey and shown that it has higher antioxidant capacity. On the other hand, Manuka honey was used as well. It is made from the bees feeding on the flowers of the Manuka bush, which are found mainly in New Zealand. Besides that, this honey has both antibacterial and antioxidant properties. This hexagon shows us the average composition of honey, whereby only 0.5% are vitamins and enzymes. However, within this small compound of honey, it contains several important antioxidants, including vitamin C, phenolic acid, catalase, and acid phosphatase. Let me define antioxidant. Antioxidant is a substance that can counteract the damage caused by oxidation from free radicals. And what are free radicals? Free radicals are reactive molecules in our bodies, either produced endogenously or from exogenous sources, and they are capable to damage our lipid, protein, DNA, and RNA. This is how a cell death can occur secondary to oxidative stress from free radicals. When we experience aging, there will be accumulation of this oxidative damage in our cells and tissues, and that's what happens during aging process. That's where our honey in our study playing its role as an antioxidant act on free radicals. And for general objective, we want to determine the oxidative status in rats supplemented with galam honey and compared to Manuka honey. For specific objectives, first we want to determine the effect of galam honey supplementation on oxidative DNA damage in young and middle-aged rats compared to Manuka honey. Secondly, we want to determine the effect of galam honey on antioxidant enzyme activities in the red blood cells and liver tissues. Thirdly, we want to compare both oxidative DNA damage and antioxidant enzyme activities between young and middle-aged rats. Lastly, we want to determine the effect of different doses of galam honey on oxidative status in young and middle-aged rats. For methodology part, after approval, we used 48 male rats, which were equally divided into 2 months old young rats and 9 months old middle-aged rats. Each different age group was further divided into 4 subgroups with different supplementation. The first group, control group. Second group, Galam honey with dosage 2.5 gram per kg. Third group, Galam honey with 5 gram per kg. And fourth group, Manuka honey with dosage of 2.5 gram. After 1 month supplementation, the rats were killed, their blood samples and liver tissues were collected. Common assay were done in the whole blood samples to detect the DNA damage level. Besides that, the activities of 3 antioxidant enzymes, including superoxide dismutase, SOD, glutathione peroxidase, GPX, and catalase, CAT, were determined in the liver tissues and red blood cells. And here are the results. For common assay, in 2 months old and 9 months old rats, we can see that the DNA damage level was significantly reduced for 2.5 gram Galam honey group, 5 gram Galam honey group, and Manuka honey group as compared to control group. For SOD activity in red blood cells, there was no significant difference in this enzyme activity comparison within all groups. For SOD activity in liver tissues, in 2 months old rats, this enzyme activity was significantly reduced for 5 gram Galam honey group. For catalase activity in red blood cells, in 2 months old rats, the enzyme activity was significantly reduced for all honey group as compared to control group, whereas for 9 months old rats, the enzyme activity was significantly reduced for 5 gram Galam honey group. For catalase activity in liver tissues, in 2 months old rats, the enzyme activity was significantly reduced in all honey group as compared to control group, whereas for 9 months old rats, the enzyme activity was significantly reduced for 5 gram Galam honey group and Manuka honey group. For GPS activity in red blood cells, in 2 months old rats, we can see that this enzyme activity was significantly increased for 5 gram Galam honey group as compared to control group. For GPS activity in liver tissues, in both 2 months old and 9 months old rats, this enzyme activity was significantly reduced in all honey group as compared to control group. Here comes the discussion part. Honey supplementation might prevent DNA damage and optimize endogenous antioxidant enzyme activities via some possible pathways. The first pathway is through the scavenger antioxidant. Again, honey contains antioxidants, and these antioxidants, they're able to directly neutralize the free radicals and resulted in downregulation of antioxidant enzyme activities, and that's what we found in our results. The second pathway is through the cofactor availability. Generally, honey contains selenium, and selenium is actually a cofactor for GPX enzyme. Therefore, increase in Galam honey dose will increase the selenium level in our body, and eventually will cause increase in the GPX enzyme activity and its concentration. Next, when GPX activity increase, catalase activity decrease. These two antioxidant enzymes, they have similar function, which is to convert the hydrogen peroxide to unharmful water and oxygen. However, in comparison, GPX is more active than catalase. Then, the antioxidant enzyme activities in the liver tissues reduce with Galam and Manuka honey supplementation. And our result was consistent with the previous study done, whereby honey will cause significant reduced oxidative stress in tissues, which indirectly reducing the antioxidant enzyme activities. From our results, different doses of honey give similar effect on DNA damage level and antioxidant enzyme activities. And our result were consistent with the previous study. Lastly, although free radical productions will increase with increasing age, however, from our results, the antioxidant enzyme activities are unaffected. In conclusion, finally we came to the conclusion part. Galam and Manuka honey reduce DNA damage level in young and middle-aged rats. Galam and Manuka honey might share the oxidative DNA damage in young and middle-aged rats and indirectly modulating antioxidant enzyme activities. As a suggestion, we all should take honey as a supplement because it can provide us many health benefits, and it may improve our health status. For acknowledgement, we would like to thank to our supervisors, all lecturers, master students, and staff of biochemistry department. And that's all for my presentation. Thank you. Any questions from judges?
Actually, I've got a question. Your title, you wanted to compare Manuka honey with Galam honey. What's the difference have you found from your study in terms of antioxidant property?
From previous study, actually different types of honey will have different antioxidant capacity. Depends on its flora sources.
No, from your study, what is the difference? Have you found a difference between Galam honey and Manuka?
No, there was in oxidative DNA damage and antioxidant enzyme activities, comparing these two honey. Yes.
Okay, in your study, you're using young and middle-aged rats. May